Well, good morning, everybody. So thank you all coming to Bristol to recognise that, in fact, the weather in England is perfect. And also coming to learn about this important topic. So I've got many old friends and some new friends, so I look forward to working with everybody, and we'll go through some basics, so terminology, diagnosis and treatment. One of the key things about the ICS is the terminology initiative. So I'm sure everybody's familiar, standardization of terminology of lower urinary tract function. It's simply too interesting to describe, isn't it? We all love it. Now, our starting point has to be micturition cycle. Storage phase, hopefully at the moment, alternating with voiding phase, back and forwards, with the vast majority of the time in storage. So our normal physiological function may go wrong, and we tend to catalogue the dysfunctions according to the timing. Storage phase problems means storage type LUTS. Voiding problems, and you will get some typical problems straight after voiding as well. That's how we put these together. And this was beautifully set out in our main standardization document, the Abrams et al. 2002 Standardization of Terminology. This is, of course, ICS flagship document, one which, as a professional standard, we really need to be pursuing as how we follow our practice. So our key papers, that's probably the main one, but there are more. So Bernie Halen led a document where the terminology focused on those relevant to female practice, female patients. Nocturia, which Hashim is responsible for revising this year. Good urodynamic practice, and that is, of course, Werner Schaefer, how we do the main standard of investigation for lower urinary tract dysfunction. And more recently, Peter Rosier has updated that document too. Now, of course, this should now read the 6th International Consultation on Incontinence, and I think Avicia has been waving and is even now waving at you. Just what a good document that is. Now, key terms in storage LUTS. Can we define them? Okay. Would anyone feel brave enough to give us a description of urgency? This is an interactive session of professionals in the field. So, of course, you will all, with great happiness, say that urgency is a sudden, compelling desire to pass urine, which is difficult to defer. Thank you for the knowing nods. Yeah, you're absolutely right. How about increased daytime frequency? Well, not exactly. It's the perception by the patient who feels he or she passes too often by day. So there isn't a threshold value. It's not 8 times, not 10 times. It's the patient feels they're going too often. And that is basically appropriate because I go to the toilet probably 10 times a day. I don't feel I go too often, and I certainly do not want anti-muscarinics, urodynamic testing, or anything like that. So if you really take a patient focus, it's what the patient perceives. And then Nocturia. Now, you're quite a quiet group, aren't you? Yeah? I have to say, I was expecting, me, I'll tell you. Oh. Hello, ex-registrar. Yes.
Once per night. More than once per night, but the patient should be awoken to go. They shouldn't be awake from chronic pain or something else already.
Well, on a slight rephrasing of that, I would say once or more often per night, waking to pass urine. So once is nocturia. So you said more than once. Well, that's probably bothersome nocturia. So once a night we don't actually ignore, we probably won't intervene because it's not bothersome, but we catalogue that it's present. So There you are. It's all in your handout. So, sudden compelling desire to pass urine, difficult to defer. You can all say this very quickly. Accompanied by a patient who feels it too often by day. Nocturia, waking at night 1 or more times to void. We can, of course, put them together and come up with overactive bladder, which is urgency, with or without urgency urinary incontinence, usually with increased daytime frequency and nocturia in the absence of other causes like urinary tract infection. So you have to exclude tumours, stones and the like. Not an interchangeable term with detrusor overactivity, which is a urodynamic observation of pressure change during filling, which may be spontaneous or provoked. Now, those are probably the absolute key ones, because when we have discussion with patients, we've got to be explicit about the nature of their symptoms, and we've got to map those symptoms onto our diagnostic and treatment pathway. And to be honest, the rest of the symptoms are rather of marginal importance compared with these ones for most of our practice. Obviously, urologists do deal with voiding LUTS, but what makes people attend is urgency and nocturia. Those are the drivers. We can mention underlying mechanisms, so neurogenic meaning that there's a relevant neurological condition. When we think about overactive bladder, we need to be very careful to define that as this bigger green circle. These are the patients with urgency, with or without urgency urinary incontinence, usually with increased daytime frequency. That's increased daytime frequency. But it's not actually, in my opinion, that often that they have nocturia. We certainly do get nocturia in association, but when you look at an OAB patient's bladder diary, it's dominated by daytime urgency and increased daytime frequency. During the night, their urgency scores are usually lower and their voids are usually bigger. And that's because when you lie down, you stabilize the overactivity of the detrusor itself. You're less likely to see the urodynamic observation of detrusor overactivity in someone that is supine. So nocturia is a separate circle with a bit of an overlap with OAB. And that's because the bulk of nocturia is down to overproduction of urine during the night, which is nocturnal polyuria. And of course, our bladder does not make the urine, it simply receives it. Then detrusor overactivity. Many OAB patients do have detrusor overactivity, but some do not. You know, these are the ones without DO. And DO can be asymptomatic. You can have a bladder contraction which the patient is not aware of, and it still counts as detrusor overactivity. So incontinence is one of the key aspects of today. The classification of that relates to physical exertion, urgency, or a combination of the two. So stress incontinence, leakage with effort or exertion, sneezing or coughing. Urgency urinary incontinence, leakage accompanied or preceded by urgency. Mixed urinary incontinence, where both are present. And then lastly, mixed incontinence, where urinary combines with fecal, which is a tough life. Now, polyuria is you make too much urine. So, strictly speaking, we use 70 kilogram adults, because most people are, of course, 70 kilograms, aren't they? Yeah? I'm 72, so I'm allowed a little bit more. It's the production of more than 2.8 litres of urine in 24 hours, so that's 40 mils per kilogram per 24 hours. So I am allowed an extra 80 mils per 24 hours to avoid being labelled as having global polyuria. Okay? some of you will struggle to be allowed 2.8 litres. Nocturnal polyuria is disproportionate amount of that daily production happening when you're asleep. And it's basically a third. We have had 20% for younger people. It just seems a bit silly, and that's probably going to be dropped from the revised document. So, waking at night to pass urine, technically each void should be preceded and followed by sleep. Of course, the intention of sleep is what matters to the patient. They've lost sleep. If they can't get back to sleep, then they're really bothered about it. So again, that will probably be amended to preceded and followed by the intention of sleep. Now, the void when you get up in the morning is not nocturia, because it is not followed by sleep. You've deliberately got out of bed ready for the day. It isn't followed by sleep, so it's not nocturia. But what you pass in that void was made when you were asleep. So it counts towards your nocturnal polyuria index. So if we look at a bladder diary, now the timing, 10 p.m, they went to bed at 10:15. They read a book for a bit, so they were just in bed, and they passed urine at 23:05, 240 mils, and they finally got to sleep at 11:10. Then they woke, passed urine, back to sleep, woke, passed urine, back to sleep, and then here they decided to get up for the day, past 320 mils. How many episodes of nocturia is that?
2.
Fantastic. How much urine was produced during the night?
890.
Yeah, you're going to add that, and that. So that's 890. So that's their nocturnal urine production. And it's expressing that volume as a proportion of the 24-hour volume that tells you if they've got nocturnal polyuria. So here we are, nocturia twice, nocturnal frequency twice, because they did get back to sleep each time. They don't have global polyuria because when you add up the entire daytime stuff, the proportion's a bit, you don't have 2.8 litres, but 890 as a proportion of all these is too high. So they have got nocturnal polyuria. Voiding LUTS, slow stream, intermittent, hesitant, straining, dribble. These are quite straightforward terms. There's nothing technical about them. They're usually understood very rapidly by the patients. So you don't really need to memorize these terms. It's pretty easy communication. Post-micturition, so that's basically they've finished the pee, but then you can have a post-micturition dribble. So a bit more comes out, but the pee had basically stopped. So it is technically post-micturition, but it's so definitely linked to the void. You can also have sensation of incomplete emptying. I've been to pass urine, I don't think I've finished. It's post-void, but that's when they're most conscious that their bladder did not empty. So it's generally categorized as a post-micturition symptom. Any questions about terminology? Do you feel confident to say that urgency is a sudden compelling desire to pass urine, which is difficult to defer? Well, I know you do. I should hope so. Anybody not feel confident? Again, this interaction is a bit of a letdown at the moment. We've got to give them some electrical shocks or something to wake them up. Next, we'll get on to a diagnostic and therapy pathway. So the EAU guidelines present quite a nice approach to following this. It's evidence-based, expert panel, strong recommendations can follow. Now, a woman presenting with incontinence, obviously take a history, physical examination, grade A recommendations for that. Questionnaire. Now, questionnaire yes or questionnaire no? Who says yes?
Yeah, we do a questionnaire.
Why do you do a questionnaire?
Yeah, it's mostly for our own purpose. Yeah.
Well, what's your purpose? To do good to the patient?
Well, our purpose is to triage if they have to go to the gynecologist or the urologist. So
Yeah.
Before they come in, we make them fill in a questionnaire, and then we make sure they arrive at the right department.
Yes.
Yeah.
Triage.
For that.
Great reason. Also so which specialty to go to, and also to focus on which problems are worst.
Yeah.
And then, of course, it's very time efficient, isn't it?
Yeah.
So within half a minute, you know all their symptoms
Yeah.
and how bothered they are. Now, everybody notice, that was called interaction. Did it hurt? It was all right, really, wasn't it?
It was all right.
It was quite painful for me, but that doesn't matter. Yeah. So, okay, we can we? So, who does not use a questionnaire? Why not?
Because I
This
like
will
to-
hurt much more.
Yeah.
Yeah.
No, it's not really something we have discussed in our group yet, but I like just to talk to the patient and see what is bothering most. And sometimes when we have a questionnaire for people who come with hematuria, but then I get this questionnaire and 1 second later the patient comes in and he thinks I know everything about it, but I don't. I only had this questionnaire not even 1 minute before he came in. So I find it more easy just to talk to them. But maybe when you have this questionnaire for triage, of course.
Yeah.
Then someone read
But
it
the
before.
talking can be, you can easily deal with that. So, just give me a moment. I see that
Yeah.
this one seems to bother you most. Can you tell me a bit more about it? And what about this? It's very easy to deal with. But if you've got it catalogued in front of you, you're already thinking, heading in the right direction, and you won't forget something. So I would strongly encourage you to think about introducing this to your practice. It's easy and it works.
I think as a human, we have this ability to forget. So I think the questionnaire, as you mentioned, lead us, to the most important things. Because sometimes I see the patient and I examine her, and then, I forgot to ask her this
Yes.
question. So,
Yes,
and
because you
it's-
have a busy clinic. Yeah.
And it's time saving.
Yes.
Basically.
Yeah, there's no question about it. Receptionist gives the questionnaire, it's handed back to you. Oh, yes, I should have asked. Thanks for telling me. It really is very helpful. Voiding diary, it basically is used predominantly in storage LUTS, but woe is it, it's just such an important routine. You identify some surprising things in some individuals, so strongly encouraging it. Urinalysis, because now we're doing a study of urodynamics in male LUTS. We've identified 4 bladder tumours through urinalysis out of 800 people. So you must have it. If you don't have it, you have no defence. It's required by guidelines. Post-void residual, it says if voiding difficulty. For men, post-void residual is routine for the majority. Maybe a pad test. And then, of course, you might identify a situation that is not a straightforward incontinence. Then you'll follow the routine pathway for those particular situations. So, just for completeness, the voiding diary, pad test and imaging recommendations of the EAU. These are not strong recommendations, and I think everybody's entitled to follow what they think is logical and in the best interests of the patient. So focusing on the patient's problem, history, symptom score, examination, urinalysis, diary, free flow, and conservative management. These are done before urodynamic testing. This is a fantastic bladder diary which is completely messed up.
It could be worse.
It could be worse. Okay. It's very odd though, isn't it? So the gist is, the person is drinking a lot of tea and coffee. They're drinking significant volumes. And here's a really important observation: 300, 500, 400, 400, 500, 400, 200 in their urine output, with a bladder sensation of 1. And they've come with storage LUTS. Now, what is the concern that we should have when we see a bladder diary like that?
Diabetes.
What sort of diabetes?
Probably type 2.
Diabetes insipidus. Yeah. So you've got to be very definite about, you've got to ask the patient, you seem to be drinking an enormous amount of liquid. Why are you drinking so much? So you'll get 2 answers. The magazine tells me that I should drink more. The magazine makes no mention of an upper limit, and therefore you drink a river. So that needs a bit of education. But the second one is, I'm always thirsty. And if that's the answer, don't recommend fluid restriction. Recommend endocrinology at once, because fluid restriction is potentially fatal. So constant thirst, you have to identify this, but then that's clearly abnormal. There's an example of an excellent flow rate. All right, this was described to me as excellent. Excellent because they had a beautiful voided volume of 968 and a fantastic maximum flow rate of 20. Is it beautiful? I'm glad it's not mine. So the only normal part is the upstroke is good, but then probably because they were overfull. And then the peak flow is actually here. So this is about 12.5. Then it declines, and then they're going into straining mode. So I bet they've got a huge post-void residual. So this is an advice to don't trust what you're told. This was described as normal, and it's grossly abnormal. Urodynamics. Do we do urodynamics for men, for women? Now in Bristol, we're strong advocates of urodynamics because we like to operate on people for the right reason. We want to know that they've got the problem. We want to know that we won't put them at risk of giving them a different problem. So the urodynamics, in our opinion, is important. We're also very careful to make sure that the experience is not too unpleasant for the patient, and that at the end of it, they're properly counselled and aware of the implications of the findings. So we would strongly recommend urodynamics. There's a particular group of people where you must do urodynamics. No discussion really. Symptoms of overactive bladder, history of previous surgery, or suspicion of voiding difficulty. And that's because this is a group in which adverse outcomes will be enriched by the nature of their problem. So good quality urodynamic studies. These are done by the ICS recommendations with one exception. The blue line should not be at the top. And that's because if it goes above, you'd miss important bits of the most important pressure reading. Everything else is reasonably straightforward. So it's been 0 to atmosphere. You're seeing resting pressures in the blue and the red lines, which are subtracting out nicely. You're seeing good cough subtraction. Coughs being done regularly throughout filling, including just before the void and after the void, so that we can be confident about pressure recording during voiding. We are seeing a nice flat detrusor. Here, this is a woman. She's been asked to stand up and do physical provocation to look for stress incontinence. No leakage is seen. Now, of course, at this time, she's not above the flow meter, so you didn't really expect to see the flow happen if the flow misses the flow meter. So perhaps the one deficit is there's not enough labeling. We would like to see some labels to see, was there leakage? What was done when? What events happened? So our only label is really voiding. And there is an excellent flow pattern, far better than the previous one. So that's a nice trace. Here's an example of the key issues that we're discussing Saturday and Sunday in Bristol. Observation number 1. This is the storage phase, but flow is happening. Therefore, there is incontinence demonstrated during urodynamics. What type of incontinence? What's this? Detrusor overactivity. So there is DO. It doesn't look high amplitude, it looks a bit pathetic, doesn't it? So you might be thinking, is this really detrusor overactivity? Well, yes, it is. Reason, it's not pathetic at all. This is almost as big as the pressure generated during voiding. Therefore, that is an extremely potent and effective detrusor overactivity. Any more incontinence? What's this? Well, cough-induced, yeah, because it's stress incontinence, so cough is a stress provocation. So the formal term is urodynamic stress incontinence. Leak. It's always a series of coughs that you need. So the first cough does usually not generate a leak. The second generates a small leak, and the third a big leak. It sets off another DO, so there's more DOI there. So the formal diagnosis is mixed urinary incontinence. So we do it because symptoms often fail to match our urodynamic observations. Now, when it comes to treatment, depends what the problem is. Stress incontinence, topic of today. Urgency incontinence, topic of tomorrow. Mixed, and this is a mistake, it should say mixed urinary incontinence, is the topic of the weekend. Now, non-surgical treatment is extremely important. We're all familiar with the need to offer containment, the appropriateness of lifestyle interventions, behavioural and physical therapies.